Starting Point Coaching and Consulting presents Kairos Conversations, Connecting with Quality, the podcast. Kairos is Greek for the right time, the right season, the right opportunity. This podcast features healthcare quality professionals who share their journeys, their advice, their struggles, how they made that transition into a new and exciting role. My heart's desire is that you find this podcast to be inspirational to you as you make your own journey. Don't forget to share this podcast with your colleagues and friends and rate us on whichever podcast platform you listen to. Thank you for being here. Thank you so much for tuning in today. Today, I am joined by my next guest, Dr. Jennie Byrne. Thank you so much for being here, Dr. Byrne.
Thanks for having me, Brandy.
All right, well, let's start by introducing yourself to the audience.
Yeah, so my name is Dr. Jennie Byrne. I trained as a psychiatrist and as a neuroscientist. So I did a combined degree, and I live currently in Chapel Hill, North Carolina. I got 2 teenagers. My husband's here as well, and we'll talk more, but I've done a bunch of different stuff in my career, so I'm excited to share some of that and maybe hear your thoughts on it as well.
Yeah, I love that Raleigh, Chapel Hill, Durham area. I used to live in Greensboro, Winston-Salem, so I'm very familiar with that area.
Oh, yeah, I love that too.
Awesome. So let's start by sharing your journey. How did you decide that you wanted to be a physician, and how did you know what you wanted to specialize in?
Well, I'll preface it by saying that it was very meandering. So I'm sure you've had guests that said they knew they wanted to be a doctor when they were like 5 years old. That was definitely not the case for me. So when I went to college, I actually was a music performance major. I played 2 classical instruments and was really quite serious about them, but got into college, quickly realized I wasn't going to make the cut for the Philadelphia Symphony Orchestra. And and then I changed gears, and I was really excited. I grew up in kind of a small town, so I was really excited to live overseas. So I switched gears. I became a French major, and I lived in France and came back from that. I loved that experience that I was like, well, I don't really want to be a French professor. I just kind of wanted to live in France. So I still didn't really know what I wanted to do as a junior. And then I took a class called Brain and Behavior. And it was kind of a new thing back then, that it was interdisciplinary, where you had biology, psychology, neuroscience, a little bit of pharmacology, a little bit of chemistry. And I just totally fell in love. I just loved it. Everything about it. I loved it. I had great professors. The topic interested me. And so the way I describe it is everything since then has kind of circled around brain and behavior in some form or fashion. So I was going to actually I did research in college, and I was going to do a PhD in neuroscience because I loved it. And someone in my lab was an MD PhD, and he said, I think you'd be a really good translational physician scientist. And so, I'm like 20 years old. I'm like, oh, sure. Okay. That sounds good. Let's just do that. So being a little naive, I guess, I went that route and did an MD PhD in basic science with neurophysiology, still thinking that I wanted to be a researcher in academia. But as I did the PhD, I kind of realized that I loved research, but at the same time, I didn't really love academics. I didn't really love super details. I really liked learning about new things and thinking big. And research is all about knowing everything about nothing. And I was much more of a generalist, I guess. And so as time went on, I started, thinking about clinical work, and I loved neurology. I loved neurosurgery. I loved psychiatry. But of all the 3, psychiatry was kind of the most interesting to me because, you can always talk to people, and I like to talk. And not that many people were going into it at that time, honestly. And I always like to kind of do what other people aren't doing. So that's the route that I went, and I ended up training in psychiatry and kept doing research through residency. But then by the end of residency, decided just to go full on clinical.
I love that. I love how you kind of shifted over time based on, what you were learning about the field of medicine. But I honestly believe that people don't really understand the difference between psychiatry and psychology.
True.
I think psychiatry is a little understood. So can you explain the difference between the two?
Yeah. And, it's interesting. I used to tell people I was a psychiatrist, but nobody knew what it was. So I started when people who didn't know me asked what I did, I would say I'm a physician. And then they'd say, what kind of physician? And then I'd say psychiatrist. So the emphasis really is that psychiatrists are medical doctors. We go through all the same training as your internal medicine doctor. Plus, we do specialty training the same way that like a cardiologist does specialty cardiology training. We do specialty training in brain and behavior. So another fact that people don't know is that psychiatry, we actually do 1/3 of our specialty work in neurology.
I didn't know that.
Yep. And our board exams are actually 1/3 neurology. So psychiatry occupies this really interesting space between internal medicine, neurology, and psychology. And I think it's a fascinating perspective and one that's actually pretty unique. It's really good for understanding that mind-brain connection.
So why do you think there's such a stigma around psychiatry? Do you think it's because people don't know what it is, or people don't understand the benefits, or where did the stigma come from?
That's a great question. Psychiatry has a pretty rocky past as a profession. Some of the earliest psychiatrists were called alienists, and they were trying to understand mental illness in the context of crime.
Mm-hmm.
And the history of the asylum. So asylums actually back in the 1700s were places where political prisoners were sent.
Mm-hmm.
So mental illness and politics and crime and things like intellectual delays or other people that were at the fringe of society in the 1700s in Europe, they were all clustered together and stuck in these asylums. So I think it's always had this stigma. Mental illness has had this stigma as being kind of, dirty or related to crime or political issues. And that's kind of unfortunately carried with us. And you can see even today, a lot of people with mental illness are housed in the prison system. And there's a lot of systemic bias. And unfortunately, that's kind of another topic. But I think the stigma is still there. And then, of course, you have the media, the popular media with movies and things. And I don't know if you've noticed, but typically the psychiatrist or the psychologist ends up being the criminal
Mm-hmm.
at the end. Yeah. And then you have other shows, like more recent shows, where you see these psychologists working with patients who cross boundaries and either have romantic relationships or become close friends with their patients. That's actually quite against the ethics code of psychiatry and psychology. But in the media, you see all these portrayals which just simply are not like reality based. So I think as a profession, it's always been pretty stigmatized. And then, of course, for the people who do have mental illness, they are extremely stigmatized. Even today, it's getting better. I do think it's getting better. But these people, unfortunately, tend to live on the fringes of society. A lot of homeless people have mental illness. A lot of people in jails have mental illness. So we have a long way to go, but I do think it's getting better. And I feel like part of what I try to do out in the world is talk about it a lot, like talking with you today. And hopefully somebody's listening that maybe didn't know those things. And I try to just be very open and honest about it and say what's good about it and what's bad about it.
Yeah, I feel like since 2020, there's been, and even a little bit before then, there's been more conversations about mental health and its reality and struggles that people have had that have been often unsaid.
Yeah.
And yet there is still a lack of access to these types of services, and especially with like healthcare professionals, because in the past with a lot of state boards, if you said that you had a mental illness or something that someone thought you couldn't treat patients, that affected your ability to practice.
Yeah.
And so how do healthcare professionals overcome that barrier of we're the closest to access and still some people don't have access or don't feel like they have access?
Mm-hmm. I'm really glad you asked that question. This is something I'm really passionate about. And I'll just tell you a quick story just to highlight as a clinician how hard it is. When I was in medical school, I started having panic attacks but I actually didn't know what they were until I got to the section on psychiatry. And then all of a sudden I realized, oh my God, I've been having panic attacks probably my whole life. And I had no idea. And then even when I did, I was very reluctant to ask for help as a med student. And I kind of just read about it and tried to figure it out on my own. And that, worked a little bit. And it wasn't until I decided to do psychiatry where I trained in New York City, and that's a very heavy psychotherapy kind of environment. And they really wanted us to do our own psychotherapy as part of our training. And so I was like, sure, I'll do it. And it wasn't until I worked with a therapist for a couple of years in New York that I really saw my own struggles with anxiety and panic attacks. And the only reason I did that was because it was part of my training and somebody told me I should do it. I never would have done it otherwise. So even personally, I can say whatever challenges I've had probably would not have been treated had I not gone into residency and had someone tell me to do that. So I think most clinicians, let's be honest, having a little bit of anxiety and a little bit of OCD can probably help you quite a bit to get through your training. Right? You have to be a little bit obsessive to get through it. But in my practice, I did have a psychiatry practice for about 9 years here in Chapel Hill. I saw a lot of clinicians, and they were not coming to me until it was really bad. And it just really surprised me. Sometimes there were these clinicians who you'd look at them and just think, wow, this person has their act together. They're top of their game. They have all these accolades. They're attractive. They're funny. They have a supportive spouse. They got research grant. Like you'd look at this person and be like, this person has everything, right? And these were the clinicians in my office crying and saying they were thinking to kill themselves.
Wow.
So it's real. And unfortunately, most clinicians wait until things are really bad before they ask for help. And even then, many don't. And we all know, not to get too downtrodden, but, suicide rates, especially in physicians, are very high. And women physicians are much greater than the general population. So anyway, part of my mission right now is writing my second book on this topic. And I'm hoping that it will reach out and touch some of those folks who may be suffering in silence and don't really understand what's going on with them, and hopefully inspire them to reach out and get help. Because, folks like you, what you're doing, and others, there are people out there who want to help. And there are ways to do it where you can be very confidential. You can get peer support. You can, not risk your license or your practice in any way.
Yeah, without giving your whole book away, what type of advice do you give for people who, are in that situation where they're waiting and waiting and waiting, and they're scared to say something, or scared of losing their license, or they feel like they're alone? What advice would you give them?
Well, my experience has been that the majority of clinicians don't know what's wrong. They feel bad inside, but they don't really know what it is. And the popular conversation right now is around burnout. And I do think there's validity to burnout, but I don't think that goes as deep as what most clinicians are feeling right now. So that's why I researched the topic of moral injury, which is different than burnout. Burnout is this kind of industrial energy metaphor, right? Where you're just exhausted and you need to go take vacations and do yoga or whatever and come back and everything will be fine. And I don't really think that's what's going on. I think that people feel bad inside and they feel wounded. And the reason they're wounded is they feel like disconnected from what they signed up for. They feel like their values are being transgressed, that they're working in a system where they can't provide the best care to patients, that nobody's hearing them, nobody understands. They're being treated like robots. And many of them are just trying to get out, frankly, at this point. So the book talks about the difference between burnout and moral injury. So I believe, again, psychiatry, the first step is to understand what you feel inside, and then to be able to put a name on it so you know what it is. And then once you know what it is, you can look at the different ways of healing. And moral injury, there are some things you can do as an individual, but in reality, the system around you, the environment has to change to really heal some of those wounds. So it's not all individual. I think as an individual, again, what you're doing, you realize that you have a lot of options. I think that's very important. Most of the time, you're not truly as stuck in your current job as you think you are because you're so heads down trying to do that work every day. So kind of being able to look up around and know what's out there. And then to find peers. I think one of the big takeaways from the book I learned is that finding peers to listen to and to talk and to have your own story be heard, that just by itself can offer some healing. And that's, I think, the first step is really knowing what you feel, being able to identify it, and then start to talk to others. And then get ready maybe to get to the coaching or to the more pragmatic things that you can do to either feel better, to leave your job, to make a change where you do work, or to even think about other career options.
That is, I love that you said that. And you mentioned how it's not just the individual that needs healing, but the system.
Yeah.
Can you elaborate on that? What do you think needs to change in order to make that happen?
So when I was researching, I learned a couple things. So first of all, healthcare, like other industries, our current mental model of healthcare comes from the Ford factory back in 1905. Before that, it was very different, right? Healthcare in the 1800s was, if you were rich, you had a doctor or a physician typically would come out to your house and treat you. And that physician, by the way, was not regulated. There were many different types of people who called themselves physicians. Some of them could have been very skilled. Some of them could have been total quacks. And they would come out to your house. And then if you were poor and you got sick, you either died or you went to like a safety net public hospital that was typically run by a charity of some kind or religious institution. So Western medicine, until recently, that was kind of the main model. So this hospital model is really post-Ford factory, post-World War II, and it envisions the patient journey and the clinician journey as akin to more of a factory. Like you have a conveyor belt, right? And you have a little widget that moves down the conveyor belt, and then the workers do things to that widget, and the widget pops out all good on the other end. That's kind of, if you've worked in clinics, most people probably have. It feels like that. And that's a pretty crappy feeling. Like as a patient, it's a terrible, I hate being roomed. That's my pet peeve. When I had a practice, I was like, no one at my practice will ever be roomed because that's just like an offensive idea to me. But we have this like factory model as opposed to what healing used to be, which was very different. So I think the environment, when your environment feels like a factory and you feel like you're a factory worker on an assembly line and your patient feels like a widget, that leads to moral injury. That's not burnout. That's different because it's the factory environment that's making everybody feel bad. So the institution has to basically break out of that mental model. And it's not as hard as people think it is. That's my other point of view is that, when I ran a practice, there were a couple things I was like, I swear I'll always be on time. I will never be late for my patients. I will never make them sit in a little room. I will never shout their name across a waiting room. I had all these things. I was like, I'll never do that. I'll never do that. And I was able to design a practice where I didn't have to do that. So it can be done and you can change the environment, but it really requires a rethinking of many of the assumptions that we currently operate under.
Yeah, it's so interesting you said that because the way you described the factory worker in the assembly line and making widgets is exactly how my audience would describe how they feel. Yes. And I've even in my own clinical practice, when I was working directly with patients, heard a leader say that about the therapist. We were money producers. We're here to make the widgets, right?
Right.
And that does cause such a disconnect between what we went to school to do
right.
and what we are being expected to do. And I think, like you said, that's where people start to decide, I want to do something else. And we would call it burnout. But what I hear you're saying is that's not really burnout. That's moral injury.
I think so. I think to me, burnout's something where if you went on a long vacation for a couple weeks and came back, you'd feel fine.
Right.
That's not what people are telling me. That's not what I experienced. it's a more profound feeling of wound. And there's other factors too. It's not just the factory. It's like feeling respected. That's huge, right? Like most people who go into clinical work either aren't making a ton of money or are smart enough and capable enough they could have done something else and made twice as much money. So clinicians, I don't believe, are primarily motivated by money. I just don't. There are things like respect. There are things like social status. Like I had one of my grandfathers was a doctor. That was the only doctor in my family. I mean, he was like a god, right? He could do no wrong. He came home and his dinner was waiting for him and his frosty beer was on the table. The children were scrubbed and ready for bed. And you talk to most clinicians, like, I bet that's not their experience.
Right.
And then you have patients coming in and pandemic, obviously, the politics, everything got so messy and people just felt so disrespected and underappreciated. And I find, again, clinicians sometimes that, if you're a clinician, you've had a really rough day and you have a patient who comes in and just says, doc, thank you for everything you do. That just lifts my spirit so much, right? Even just that one sentence from someone. They don't have to bring me a present that's always fun. But, just that genuine appreciation or just the genuine, like, thank you for taking care of me. Thank you for taking care of my family. It means a lot to me that you're here for me. Like those kinds of things lift your spirits and get you through a hard day. And so I think the moral injury, it's like a wound. I think about, we understand wounds, right? Like you can have a superficial wound. You can have a wound where the surface is breached. Then you can have a deep wound that's infected. And then you can have those really nasty wounds that go all the way down to the bone. I think moral injury wounds are similar. Some of them are superficial or pretty easy to heal. Some of them are deeper. But again, my point of view is that part of what is healing is human connection. It's not just knowing the most recent medicines and, doing algorithms and prescribing things. And honestly, if that's all it was, then robots probably could do a better job because there's so much information to know. It's almost impossible to keep up. If that's the only value of a clinician, then sure, just get a robot. But I don't believe that's how human beings heal. I think that human connection and really being seen and heard and understanding the other person's story, I believe that's what healing is.
Yeah, I love that. And it made me just think about people who have expressed that they've had post-traumatic stress.
Yeah.
How this lack of respect, feeling like a factory worker, feeling like a widget maker is leading to moral injury. It's kind of like, or how I see it in my mind, it's kind of like someone who's been through such a traumatic event that now they're in this post-traumatic stress state.
Yeah, it's interesting you say that because the conversation around moral injury and PTSD comes from the military experience. And that's where the concept of moral injury actually came from. Was from, soldiers would be coming back, especially like in the 90s and early 2000s. And it was like, well, some of what they have seems to be PTSD. Some of what they have seems to be depression. But then there's something else. Something has wounded them in a way that they're not able to reintegrate with their families and their communities. And that's how this idea of moral injury came up. And the way the military defines it is how I define it, which is there are three things. The first is that you do something, witness something, part of something that goes against your core values. The second is that it's either ordered or sanctioned by somebody superior to you. And the third is that the stakes are high. So if you think about it that way, it's a little different than PTSD, right? PTSD is kind of this I see PTSD as this very brain and body related phenomenon where your amygdala is just totally off kilter, which is impacting how your brain and your body function. Whereas a moral injury is kind of like this deep wound. It's almost like a wound on your soul.
Yeah, that's deep.
Yeah, and my colleague here in Durham, Dr. Warren Kinghorn, was the one who introduced me to this as I was talking to people. And he's really interesting because he's a psychiatrist, but he's also at the Divinity School, and he also works at the VA. So he kind of sits at this intersection of psychiatry, religion, or I guess faith, and military experience. And so he has some very profound thoughts on it. And I stole some of his ideas for the book. I quote him quite a bit in there, but it is deep. And again, I just think people are not aware what they're feeling. They just feel bad and they just want it to stop, right? Like something just feels really bad inside.
Right. The biggest mistake I see clinicians make when transitioning away from direct patient care is applying for every available role. Problem is, it's like throwing darts at a board, hoping something sticks. And let's be real, employers can sniff this out like a canine, and it makes the candidate come off as unfocused. The solution, my friend? Do some deep introspective work to identify your passions, skills, and strengths, and find roles that align with that. That's why I've partnered with Career Clinic, who created the healthcare career profile that I wish I had created first. It's called Stream Ahead, and it takes about 10 minutes to complete. It is time well spent to get detailed report of the top work streams that fit who you are. I'll link the assessment in the show notes section of this podcast. And you can use the code BRANDY10, that's BRANDY10 for 10% off. Now let's get back to today's episode. Earlier you said, clinicians have options outside of what they're doing now. So if they're feeling this moral injury and they're feeling like, they're alone or there's nothing next, and yet there's a lot of options that they don't even know is available. I know that you've worked in the startup space too, and I have a lot of my audience who are interested in that space. What can you share about the startup space from a clinician perspective and clinicians getting into that space?
Well, first of all, I think we need clinicians helping in that space. I think clinicians are better at business than they think they are. I think clinicians are better at designing clinical products than they think they are. They just have never been trained in it. So I've had a lot of real world experience in product design and business, and it's not something we learn in school. But I think that many clinicians actually are really good at that. They just have to, be curious and learn. The thing about startup is that it's almost like the opposite of a traditional clinical practice. So traditional clinical practices are kind of steady, repetitive, following algorithms, best practices. And startup world is a little bit like the Wild West. So I think if you're somebody that really likes ambiguity and you really like change and you like pivoting and doing different things, it's a great fit. But a lot of clinicians, that's not their temperament. So they can help with startups, but they may not want to work full time in a startup because that environment may feel too wild for them.
So how did you make your first step, your first interest point into a startup? Did you know somebody who kind of referred you, or did you, find a job posting for a startup, or how did that work?
Well, I guess technically my first startup was my practice, because I started a practice because I felt like things could be better, right? I had this idea, I can do this my way. I can figure this out. I had a very supportive spouse who was kind of working a more traditional 9-to-5. I had a little freedom of movement. I had little kids. I wanted a lot of flexibility. And so I kind of made a big leap. So I would say my first startup was my practice. And I did that all by myself. So we call that a solopreneur practice. I didn't get called a bootstrap, right? I didn't have any investors. I didn't have any partner. It was literally just me figuring it out. So in a way, that was my first startup. But then later, I was always somebody who wanted to fix things and thought things could be better. And so probably your audience, there are folks who are like that too. I actually got involved in bigger companies before I went to startups. So when I was at my private practice, I got involved in the statewide Medicaid organization in North Carolina. It's called Community Care of North Carolina, where that was the first place where I wasn't seeing patients. So I was being what's called a medical director, right? Where I'm doing more of the policy and the oversight and helping. At that time, I was helping primary care doctors and Medicaid, but I wasn't seeing patients. So that was the first time I had a job where I wasn't seeing any patients. And then I went to a national organization called CareMore, which is kind of a very complicated organization that's national. And I led their behavioral health for the whole country. And then they liked how I handled it. So they gave me all of the other specialty care. And so I learned a ton about specialty care, value-based care. Anyway, long story to say, I don't love working in big organizations. So it was really after that I made more of an intentional decision to look for smaller companies. And I started originally just interviewing for chief medical officer jobs. But every time I would interview, I'd be like, well, I don't know. I'm not quite exactly what you need. I don't know if I really want to jump into that, but let me see if I can help you. And so I started advising instead of becoming a CMO. And I did that a couple times. And then I was like, oh, I'm an advisor now. And so that's kind of been what I've been doing the last couple of years. So I can't say all of this. I wish I could say, Brandon, this was like all intentional, but to be honest, it's not. But I do love working with startups because I feel like if I'm one of the first people there, and normally I'm the first clinician there, I can make a really big impact, especially on some of the mental health ones I've worked with, really like put this imprint to get it off to the right foot. And then what I love to do the most is find somebody a little more junior and kind of be their mentor and help them take on the reins of the company. So I love kind of that coaching, mentoring to help take somebody who is maybe like a medical director and make them into a chief medical officer, or take somebody who's a clinician and help them become a medical director. Because part of my goal is to grow the leadership force in medicine, but specifically in psychiatry, because I believe one of the fixes to moral injury and all these other problems is really to have more clinical leadership that understands the language of business, understands the language of finance and operations. Because sometimes you have these clinical leaders who are there and they're very passionate and servant leaders, but all they do is kind of yell at the finance people. And I can tell you, like, that doesn't go off too well. Like, the finance people aren't evil villains, like this is not a villain story. Like, if you want to make change, you have to find common language. And my experience has been, if you really use your empathy skills with the other leaders, they listen to you and they will change. But you have to find that empathy for them, and you have to find that common language. If you just go and yell at them and say, you need to change everything, the clinicians are unhappy, you're bad, they're good, like that just doesn't get you anywhere. And unfortunately, a lot of the clinical leaders are so frustrated. That's what ends up happening.
Yeah, I mean, you're right. You have to understand both sides of it, because at the end of the day, it's still a business. So you still have to be able to be financially sound. In terms of mentorship, what would you recommend for people? Because I have people in my audience where it's very hard for them to take that step to reach out to someone to be their mentor, right? So
right.
How do they make that initial connection with somebody like you? Or what do they say so that they don't sound salesy, or they don't sound weird, or they don't sound whatever that feeling is that's keeping them from reaching out?
Yeah, there's actually, when I wrote my first book, the person that helped me with that, he wrote a book called Super Mentors. And it's a light read, but there are some very practical tips there about finding good mentors. So I guess my advice would be, the first thing is to operate a little bit in stealth mode. So do some Googling, go to LinkedIn's actually a pretty good place to learn things about people. Follow some people, read what they've written. If you see what someone's posted on LinkedIn, what their website says, some articles they've written, you can kind of learn a lot about somebody. So do a little homework. And then when you're asking for advice or mentorship, one of the tips from this other book is that get really specific with your ask. Like, don't say, I want you to mentor me. Because when somebody hears that, they're like, I don't know what that means. Like, do they want to talk to me an hour a week? Like, I can't do that. Or, I'd make it very specific. Like, hey, I've been reading your work. I really like the article you wrote on blah, 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 blah. And I'm wondering if you could give me some advice on blah, 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 blah. If you could spare 15 minutes, I would really appreciate it. And then ask them for a very brief, 15-minute conversation. Don't ask them for an hour. Just ask them for 15 minutes.
An hour is probably not going to happen.
No, it's not. And, make a calendar link so that it's easy for them. Ask them permission before you send it to them. So say, hey, I've been following you. I love what you said here, blah, blah. I'd love to learn a little bit more. Would it be okay if I sent you my calendar link for a 15-minute call? So ask permission. Don't just send them stuff. And then if they say sure, then say, oh, thank you so much. Here's my calendar link. I just love to pick your brain for 15 minutes. Most people, again, this is the psychology part. Most people love to give advice.
Mm-hmm.
So if you ask them for advice in a small, easy to execute way that's very specific, most people are willing to give you advice. And you'll be surprised sometimes at who will talk to you.
Yeah, and you're respecting their time too, right? You're saying, I know something about you, so you're not coming in cold. I'm respecting your time, and this is exactly what I want to know. That way they can make the decision on whether that fits into their schedule or fits into their ability to do.
Right. And if they can't talk to you on the phone, say, oh, thank you anyway. Do you have another resource you would recommend or another person you recommend I talk to? And then maybe they can direct you somewhere else. Another really good tip I learned over the years is the idea, it's kind of a psychological construct about reciprocity.
Mm-hmm.
So Adam Grant, who's a psychologist, wrote a book called Give and Take. And there's this idea from that book, which we call the 5-minute favor. So if you do a 5-minute favor for someone, something that's easy, takes you 5 minutes, but has value to that person, they will feel a sense of reciprocity. And most people will feel like they want to give back to you. So if I'm, wanting to chat with Brandy, I might go to her podcast and I might listen to a podcast and then I might leave a review and say 5-star, this was a great podcast. I really loved at, minute 2:30 where Brandy was talking about this topic that really resonated with me because blah, blah, blah. And then Brandy's going to see that, right? And you're going to say, oh, that was really nice. I'm really glad that, this doctor took the time to say that. And then you might feel like when I reach out to you on LinkedIn, you're like, oh, I know you. You left me that review. Yeah, okay, I'll talk to you. So before you even reach out, if there's a way that you can do a 5-minute favor, commenting on someone's post, sharing it, making an introduction, sending someone an article you think they're interested in, something that just takes you 5 minutes, often that will generate a really positive feeling in the other person and make it more likely that they want to help you.
This is absolutely golden. I hope people are really listening to this because this is how we can make it non-transactional, because no one wants to feel like someone is just coming to them for a transaction or for what I can give you only.
Yeah. And then I would also add that if you meet somebody who is a coach or who you really think has the ability to help you as a coach, you really need to think about making some financial investment in it. I think sometimes people want to have a coach but don't want to pay for it. And I can totally relate to that. I've been bootstrapped many times. I've been broke at the practice many times. But again, think about it as if you really want to advance in your career, try something different or meet new people, that's an investment. And, you might want to sit down and look at your budget, look at your, significant other and talk about your career and where you want to get to and what impact that would have on your lives if you could make a change, and then come up with a budget. And if you don't have enough money, maybe you need to start putting aside a little bit every week until you're ready to invest in that. Because I do think there's a little bit of skin in the game. I've done mentoring where I just have informal chats with people all the time. But when somebody really wants to coach with me, I'll be like, okay, let's do a coaching agreement. Let's do this for real. And then I will ask them to pay me for the coaching. And it's an investment. And I do notice that when you put that skin in and I've done this myself, by the way, I've had coaches where I've paid them and it hurt, it hurt my budget, pay for them, but it was worth every cent. And I think you have a little bit more skin in the game when you're paying for it, to be totally honest with you.
I 100% agree, because there's so much free information out here. And now there's, Chat GPT and all of these other things that sometimes people want other people's time for free. And I love what you said, that there is some value in investing in yourself to get that person's time, knowledge, experience, which will shorten your journey.
Yeah. And I think that's a hard conversation, again, for a clinician who's in the weeds, feels like they're barely paying the bills, they're exhausted, they don't feel good. Their spouse is like, why are you so grumpy all the time? I get it that it's really hard to say I'm going to spend money on myself like that, because I've been in that situation. And I know the folks I've coached have been in that situation. And It's hard. But if you really, if you really want to make this leap, I think doing research and listening to podcasts like this and that informal LinkedIn, reading stuff, liking, like you can do all that for free. But if you get to that point where you really want to make that big change, I would consider making that investment. I mean, think about how much money we pay to go to school, right? Like, I don't know how much you paid. I had a scholarship and I still was deeply in debt when I graduated. Like, we invested in ourselves to become a clinician. And I think if you really want to make a big change, sometimes you have to invest in yourself again.
Yeah, absolutely. And I've been where you're talking about too, where I needed a coach, and I felt the money leaving my account when I paid the person to coach me.
Me too.
But it was worth it.
But I bet you did your homework. I bet in between coaching sessions, you did your homework, and I bet you made the most of it, right? I know I did when I had to pay for it.
Absolutely, 100%. And that's one of the things the coaches said to me is, Brandy, I like working with you because I know you're going to do the work. Yes, I am paying you. I am going to do the work. So I love that you said that. Well, this has been such a delightful conversation, and I appreciate your raw authenticity. I hope people can feel the genuineness of what you're saying come across the airwaves. How can people connect with you?
So the best way to connect with me is on LinkedIn. If you want to be in stealth mode, you can just follow me there. If you want to reach out and connect with me and say, hey, I heard your podcast with Brandy, I will definitely accept your connection. That's probably the best way. And then in terms of like, if you want to learn more about moral injury and you check out my new book, that's probably a great way to go deeper in that topic and still be a little bit in stealth mode. If you want to reach out to me for deeper help, whether that's a coaching arrangement or, I do clinically still treat physicians. I love doing that as well. Again, just find me on LinkedIn, grab me and just say, hey, I heard your podcast with Brandy and here's what I'm thinking. And I'm very open. And if it's not me and I'm not the right person to help you, I'll do my absolute best to connect you with somebody else in my network who I think can help you.
I love this. And I'll put the links to all the ways that you can connect with Jennie Byrne in the show notes so that you can just click right on it and connect with her. I really appreciate you being here, and I appreciate you for sharing all of your gems with my audience.
Well, thank you. I really appreciate the invite, and I hope someone out there listening, hopefully something has resonated with you and maybe inspires you to take a next step, because we all need clinicians. We're all going to be patients someday. If we're not already, we all need healing. And I really hope that the clinicians who are out there find a way to continue being healers in a way that works for them.
Thank you so much for listening to the show. It would mean a lot if you would share this episode with a friend or a colleague. I would be honored to encourage them in their journey too.